Hello everyone. This week we will explore theories and risk and protective factors in preventing substance misuse. You should be able to identify and relate to the integrated model the risk, resilience, and protective factors related to substance use and abuse. Next, you should be able to explain the continuum of care model and its relationship with prevention strategies. You will be able to describe the evidence-informed prevention strategies, as well as explain theory integration and main principles of the Transtheoretical model. And finally, you will be able to define key terms related to prevention and intervention in substance use, misuse, and disorders. Let's talk about theory integration and prevention. The biopsychosocial perspective integrates multiple biological, psychological, and social context theories and models to address substance use, substance misuse, and substance use disorders. The vulnerability, resilience, risk, and protective factors framework also taps into the social work person and environment strengths perspective. This framework was derived from James Anthony's early work concerning the etiology of schizophrenia. When applying vulnerability, resilience, risk, and protective factors framework, the first step is to specify the problem. Specificity might include specifics of an addictive behavior. For instance, is it about a specific substance, type of technology, or form of gambling? Also, think about target population, their age or developmental phase, racial or ethnic group, self-defined gender identity, sexual orientation, co-occurring problems, or problem severity level. The next step is to define the relevant continuum from vulnerability to resilience. It includes factors intrinsic to individuals. These include the factors like genetics, neurobiology, and other biological processes, temperament and personality characteristics, abilities and disabilities, co-occurring problems, past experiences and learning, and current attitudes, beliefs, knowledge, and behavior patterns. Some factors reflect individuals' vulnerability to the specified problem, other factors reflect aspects of their resilience. The next step is to look at the continuum from risk to protective factors. Here we examine extrinsic factors. In other words, factors that reside in the current social and environmental contexts. For example, history of trauma, exposure to advertising of cannabis, alcohol and tobacco in the neighborhood, easy access to drugs in the community are all examples of risk factors. The final steps is to bring together the vulnerability to resilience continuum with the risk to protection continuum. At this slide, you can see a conceptual diagram, as a 2x2 grid, specifying the general probability for developing the specified problem under these complex circumstances. The Substance Abuse and Mental Health Services Administration produced a fact sheet, through the Center for the Application of Prevention Technologies, discussing prevention as part of a behavioral health continuum of care. This continuum of care framework is applicable to intervening around substance misuse and substance use disorders. Promotion. Promotion strategies are strengths-based interventions, designed to build resilience and promote well-being. Prevention. Universal prevention are interventions that are delivered to the general population, without differentiating between persons at different risk levels. For example, schools may deliver drug awareness and resistance education programming to all students regardless whether they belong to a vulnerability or risk group. Selective prevention is more targeted than universal, and these interventions would be directed towards populations identified as having a potential somewhat greater than the general population for developing problem use. For example, it might be aimed at youth who live with one or more parents or family members engaged in substance misuse. The indicated prevention is even more targeted, delivered to individuals showing warning signs foreshadowing the development of the problem use. For example, to prevent alcohol use disorder, interventions might be directed to youth or emerging adults engaged in binge drinking. Treatment services are for people diagnosed with a substance use or other behavioral health disorder. Recovery. Recovery services support individuals' compliance with long-term treatment and aftercare. Different risk and protective factors affect individuals across the lifespan. In infancy and early childhood, being raised in the family with parental substance abuse or having a difficult temperament can be the risk factors, while secure attachment and good self-regulation, support from parents and early access to high-quality learning environments could protect a child from future substance abuse. In middle childhood, children are supposed to learn how to make friends, get along with peers, and learn appropriate behaviors in social settings. Having poor impulse control, behavioral problems, and being raised in the family with high conflict are some of the well-known risk factors. On the other hand, mastery of academic skills, consistent discipline, healthy peer groups, effective classroom management, and absence of bullying are among important protective factors. Adolescents focus on developing good health habits, practice critical and rational thinking, seek supportive relationships, and extend autonomy skills. The factors that can put adolescents at risk for substance use disorder include conduct disorder, lack of parent supervision, and school failure. Factors that can protect adolescents from substance abuse include positive physical development, academic achievement, emotional self-regulation, supportive relationship with parents, and presence of mentors and support for development of skills and interests. In early adulthood, people learn to balance autonomy with relationships to family, make independent decisions, and become financially independent. Risk factors in this period include lack of commitment to adult roles, college attendance, while the protective factors include subjective sense of adult status, subjective sense of self-sufficiency, making independent decisions, behavioral and emotional autonomy, and connectedness to adults outside of family. Harm reduction. The goal of harm reduction is to reduce potential harms to individuals, families, communities, and society associated with substance use disorder, even if the substance use behavior does not end. For example, it can reduce an individual's risk of infection, accidental injury, or disease exposure associated with substance misuse, reduce the chances of accidental overdose, or protect from criminal and sexual violence associated with substance use. On this slide you can see the different types of prevention approaches. The transtheoretical model of behavior change is a model of the processes and stages typically experienced in the course of intentional behavior change. The model originally emerged in transtheoretical analysis of psychotherapies and was described by Prochaska and DiClemente. It was then applied to process of change in smoking behavior and other addictive behaviors. The developers distilled from research and clinical observation a set of principles describing behavior change processes and factors that facilitate or pose barriers to achieving change goals. The change is seen as a circular and not linear process. Pre-contemplation is the absence of an intent to change the identified behavior. A person in the contemplation stage demonstrates awareness of a problem and serious consideration of making a change, without making a specific change commitment. The preparation stage extends beyond an intent to change to include early change behaviors toward the goal of taking serious action within the next 30 days. People will have set a plan in motion, even if not actively engaged in it yet, and have set a target day for the action to begin. The action stage is characterized by a person actively taking very specific, concrete steps to change the target behavior and keep the change momentum going. For a behavior as complex as quitting drinking, for example, the person may engage in a host of strategic alternative behaviors, including avoiding the people, places, and situations that tempt them to drink, applying strategies for controlling their mood and stress management, grocery shopping online to avoid impulse alcohol purchases in the store. Once a person has engaged in action behaviors for at least 6 months, they may move into a maintenance phase, which is a period of continued vigilance against relapsing to the past behavior. Understanding the change process is incomplete without recognizing what relapse is and how it might be addressed. Ideally, we want to prevent relapse to the old behavior whenever possible, but as the evidence indicates, relapse happens. First, a distinction is made between a recurrence or slip and a full-blown relapse event. A lapse or slip is time or event limited. One does it once or more times for a short period, quickly regrets the lapse, and gets back to renewed action. The circumstances surrounding a lapse can be effectively used as a learning experience to strengthen the ongoing change effort for the future. Relapse refers to a return to the old pattern of behavior with no intention of changing again. One is spiraling back to pre-contemplation. A lapse, relapse, or impending relapse can happen at any point in the change process. Relapse is a process, rather than an event, that starts before substance use occurs again. It includes 3 parts. The emotional process of relapse is characterized by a lack of emotional, psychological, and physical care. This contributes to the kinds of negative emotional states involved in substance misuse: stress, tension, restlessness, anxiety, fatigue, irritability, and discontent. The mental relapse process concerns declining cognitive resistance to relapse, increased sensitivity to use messages, framing past use more positively, glamorizing it and minimizing consequences, entering into bargaining about use. The physical relapse involves actual substance use or misuse, and a return to the uncontrolled substance use. One-time substance use may not lead to further uncontrolled use, or it may contribute to the emotional and mental relapse processes that, in turn, lead to physical relapse. Relapse prevention involves anticipating and addressing all 3 parts, emotional, mental, and physical, and having in place plans for identifying, assessing, and developing exit strategies for the different threats. Decisional balance. Decisional balance underlies the ambivalence identified and addressed through motivational interviewing. Eliciting and sustaining motivation for change often requires addressing ambivalence, not just emphasizing the advantages of changing and disadvantages of not changing the behavior. Self-efficacy for change. Self-efficacy for change is involved in each stage of the intentional behavior change process. It represents a person's belief that change or maintaining change is possible. People might believe they just can't do it. Two strategies for assisting with motivation in this situation are: 1. Focus on ways that they have succeeded in the past, and 2. Examining how others most like themselves have managed the change process. A conversation that might elicit self-efficacy involves a change ruler whereby a person indicates on a scale from 1 to 10 how confident they are in their ability to make the desired change. Rather than asking why not 10, the question is often framed as, why not a 0? Matching intervention strategies to where the person is with their change process, achieving the right timing, is an important consideration. Action-oriented interventions might not be effective if a person is not in the action stage. Likewise, someone who is in the action stage might get frustrated because therapist is focusing on why they need to change.